Hi everyone, I am back with another episode of the Good Mood podcast. I'm Dr. Talia Marcheggiani. I'm a naturopathic doctor and a registered psychotherapist in Ontario. And I thought I'd do something a little different because I've been seeing lots of patients in the last few weeks who are bringing in their blood work. And some of them have gotten blood work ordered from their family doctors and they're being told they have high cholesterol. And I thought I'd do an educational video that you can save and go and have your cholesterol blood work in front of you and go through it much the way that I talk to patients when we go through their cholesterol panel. Because a cholesterol panel is pretty nuanced. There's a lot of moving parts. When we're told that we have high cholesterol, it might mean that one number is high in that panel, and that can mean very different things. So I encourage you to save the link for this podcast and look at it with your cholesterol panel and use it as an educational material that you can return to so that you can understand your own body and your own health and your own personal cardiovascular risk. So this podcast is called When You're Told You Have High Cholesterol. So when patients, tell me, they say that they go and they get their yearly blood work done, and often a lipid panel or a cholesterol panel is checked off. And sometimes they get a call from their general practitioner, their family doctor, or nurse practitioner, and they're told that their cholesterol is high. And maybe they're told to do something with their diet. It's often remove fat or take out eggs, or remove cholesterol from the diet. So this is very old, long debunked advice. Maybe they're suggested to come back in to start a statin, or maybe you're just told, very often this is the case, to just watch and retest. But very often patients are alarmed by this because they've never been told they've had high cholesterol before. They don't know what it means. And many are scared to go on medication or require a medication for life. So the questions I always have when patients tell me that they've been told their cholesterol's high is, and questions that I want you to ask, if you've been told or if you found their cholesterol high, is what does high actually mean in the context of this lipid panel? Importantly, which number is high or which numbers are high? How high are they? In what context? And the idea is that cholesterol is not just one number. Cholesterol is actually a story about your whole metabolism and how your body is moving fat in the bloodstream, but also how insulin sensitive you are, inflammation levels, the health of your liver. There's a lot of information that we can gather from a cholesterol panel. And so it's a relatively inexpensive test. It's a relatively routine test. It's often tested every year with regular blood work. And there's so much we can learn about your health from dissecting that blood work. So first of all, cholesterol is not bad. We've been conditioned to, or taught, the message has been hammered in that cholesterol is a bad thing. It's bad in food, it's bad in your body. But cholesterol is actually an essential structural molecule in the human body. So every cell is surrounded by a membrane. It's kind of like the skin. So your body's made of trillions of cells, and your cells are kept intact by a cell membrane. It's kind of like the skin on the outside of a cell. And these cell membranes are made of phospholipids, proteins, and cholesterol. And the membrane is not just a barrier keeping things inside the cell that belong inside and things outside the cell that belong outside. It also regulates signaling, so how each cell talks to other cells, how things are transported through the cell membrane, and communication between cells. As you can see in the picture above, cell membranes have a lot of things going on. And cholesterol sits within the membrane and it modulates and regulates its fluidity. Membranes shouldn't be too rigid, and they also shouldn't be too permeable and fall apart. You also need receptors on the outside of the cells for things to communicate. Like insulin is a hormone that communicates via cell membranes. Ion channels that regulate an electrical impulse inside cells and allow it to function properly. And so cholesterol is a very important component of cell membranes because it regulates how fluid and how permeable the cell membrane is. Things like insulin receptors, neurotransmitter, so serotonin, dopamine receptors, and other hormone receptors all depend on proper membrane structure. And cholesterol stabilizes membranes so that these signaling systems work efficiently. Cholesterol is also the precursor to all steroid hormones. So the hormones that you've heard of before, estrogen, progesterone, testosterone, cortisol, our stress hormone, but it's also our healing hormone and essential for functioning and for being alive. DHEA and vitamin D are all synthesized from cholesterol. They all start off as a cholesterol molecule and then they get synthesized into the hormone that does all the things. Without adequate cholesterol availability, steroid hormone production is impaired. And therefore, you can't make estrogen if you don't have enough cholesterol precursor to make it from. And this is one reason why cholesterol is biologically necessary and tightly regulated by the body. The liver produces cholesterol because it's required for survival. And this is part of the reason why low cholesterol diets have been debunked, because just by restricting dietary cholesterol, it doesn't lower your cholesterol, your liver just makes more. The brain is also highly fat or lipid rich, and so the brain synthesizes most of its own cholesterol locally, but cholesterol is critical for synapse formation. This is the space between brain cells where communication occurs. Myelin production, this is the protective coating on the outside of nerves that allow signals to transmit quickly, and neuronal repair. Myelin, which insulates nerve fibers and allows efficient electrical conduction, contains substantial cholesterol. We often talk about this when we feel this kind of raw anxiety. I often think about this as a low cholesterol or low fat condition. Like you feel like your electrical wiring is short circuiting because there isn't enough fat or myelin to kind of coat the nerve cells. Synaptic membranes require cholesterol for proper receptor function and for neurotransmission. And some studies show associations between very low cholesterol and increased rates of mental health symptoms like depression, impulsivity, and even suicidality, aggression. There's some studies in the Lancet that show that if you lower cholesterol very aggressively, it can result in non-cardiac deaths. Essentially, there's a U curve of optimal cholesterol. And so when your cholesterol is very, very low, the risk of all-cause mortality is higher. And of course, when cholesterol is very, very high, the risk of all-cause mortality goes up as well. But there's a sweet spot where cholesterol is in a good zone for optimal brain functioning. So cholesterol is also important in serotonin signaling. Serotonin receptors are embedded in neuronal membranes. Remember that serotonin is a feel-good neurochemical. Essentially, it's like the happy hormone. It is what is acted upon with selective serotonin reuptake inhibitors prescribed for depression and anxiety, obsessive compulsive disorder. Membrane cholesterol content influences receptor exposure and receptor function, and very low cholesterol levels may alter membranes and affect serotonin signaling. We also need cholesterol for neurosteroids that regulate GABA, which is a calming chemical in the brain, and stress responses. And so extremely low cholesterol can impact mood. So current cardiology guidelines focuses less on total cholesterol, which we'll talk about in a second, and more on LDL particle number, or ApoB. It should look at inflammation, metabolic health, and overall cardiovascular risk. But as we're going to talk about, cholesterol becomes problematic in the context of endothelial injury, so injury to the inside of the blood vessels, inflammation, insulin resistance, and when you have high concentrations of atherogenic or plaque-forming particles. So I just wanted to start, this is pretty technical beginning, but cholesterol is not inherently harmful. It's structurally necessary for cell membranes, it's required for hormone production, and it's critical for brain function. So cardiovascular risk is part of cholesterol. Cholesterol is involved in cardiovascular risk, but cardiovascular risk is also determined by a broader metabolic and inflammatory environment, not just the presence of high cholesterol. So keep that in mind. But let's talk about the bad. Like, why do we care about cholesterol then? If it's so great, why are we measuring it? Why is there so much attention on it and so much attention to lowering cholesterol. Well, the mixed messaging exists because while cholesterol is biologically essential, it's also centrally involved in a process called atherosclerosis. So when your doctor is worried about your cholesterol levels, it's not because of cell membranes or hormone production. It's because your doctor's worried about cardiovascular endpoints like heart attack, stroke, and cardiovascular related conditions that can cause death. So lots of studies involving cholesterol look at all-cause mortality. And atherosclerosis is the process that underlies these conditions like heart attack and stroke. It begins with injury of the blood vessel. So we've got blood vessels all through our body where blood flows. They're lined with an endothelium. Then there's muscles along the blood vessel that helps pump blood. And this endothelium becomes either dysfunctional or injured. And factors that can contribute to endothelial injury are smoking, hypertension, diabetes, insulin resistance, systemic inflammation. And in that environment, circulating LDL particles or ApoB, so sort of bad cholesterol particles, so we'll talk about these later, but ApoB containing lipoproteins, they enter the arterial wall. They're not doing it because they're evil. They might be involved in responding to the injury and trying to fix it. But once they stick within the endothelial wall, they become oxidized and stuck there. And they trigger an inflammatory response of their own. And over time, this leads to a formation of plaque. And plaques can start to narrow arteries or even rupture, causing clots and getting lodged in smaller arteries and causing blockages. And this can result in myocardial infarctions or ischemic strokes. So when we talk about lowering cholesterol, what we're actually targeting is reducing the number of atherogenic lipoproteins in circulation, especially LDL particles. So the more of these ApoB containing or bad cholesterol particles present, the greater the probability that some are going to be stuck to the arterial wall. And so this is why we look at ApoB, and we'll talk about that. And we also look at LDL cholesterol. This is why we care about cholesterol, because we're worried about this effect occurring. And so we also have a lot of trials showing that lowering LDL cholesterol with the most famous and most widely prescribed medications, statins, reduces the risk of cardiovascular events. And this is particularly true in high-risk populations or people who've already had a cardiovascular incident, so a heart attack or stroke, or people with established cardiovascular disease. And the reduction is well documented. And so this is why cholesterol lowering is emphasized. It's not because cholesterol causes a heart attack, it's because it is required for the process of a heart attack to occur. And research shows that lowering it with medication can prevent all-cause mortality, but essentially cardiovascular disease. And the endpoints that are studied are, non-fatal myocardial infarction, stroke, the need for revascularization, and cardiovascular mortality. And many trials look at all-cause mortality. So when we look at population-wide messaging, this looks like a simplified message like high cholesterol is bad. And partly because this simplification is practical when it comes to public health, we're trying to send a message. There's often a quick kind of soundbite that we're supposed to internalize. And this is why I'm presenting this lecture, because I want you to really understand what it means so that you can take action, you can have agency over your health, and you can understand your own cholesterol and make decisions or bring these questions to your healthcare provider. Because cardiovascular disease remains one of the leading causes of death globally, and so public health messaging wants to reduce these modifiable risk factors. And LDL lowering is one of the most consistently validated interventions for reducing cardiovascular events, especially in appropriately selected patients. So the idea is if you tell everyone to worry about their cholesterol and lower their LDL if high, this can bring down potentially cardiovascular disease rates globally, and this is good for the population. But when it comes to the individual person, the story is much more nuanced than that. So cholesterol in itself is not toxic. It's the interaction between these atherogenic particles and the susceptible arterial wall, right? So context matters. So somebody with high LDL who has everything else normal, so bad cholesterol, but everything else normal, so low blood pressure, no diabetes, low inflammation, no plaque burden, they have a very different risk profile than somebody with high LDL plus metabolic syndrome and systemic inflammation. So on an individual level, context matters a lot. And this is where you come in. We want to look at all of the factors. If you have high cholesterol, you find that you do have high atherogenic particle numbers. What does that mean for you? And how does that influence your decision making or how you work with your practitioner? So when we talk about lowering cholesterol, what we're actually talking about is reducing atherosclerotic cardiovascular disease risk. So the goal is fewer heart attacks, fewer strokes, lower cardiovascular mortality. The debate is not about whether cholesterol is necessary for life, because it is, but it's about how much circulating atherogenic particle burden is safe in the context of an individual's overall risk. So the cholesterol panel involves total cholesterol. Here I have my cholesterol panel from 2018. It's the only one I could find. I didn't want to use it. Obviously, I'm not going to use a patient, so I use my own. And so in 2018, I was actually on a ketogenic diet, and it was working out pretty well for me according to my lipid panel. My HDL was very high. My LDL was quite low. Triglycerides were quite low. But a cholesterol panel looks at a bunch of different things. So the first marker is triglycerides. We also have cholesterol, which means total cholesterol. We have HDL, or high density lipoprotein, often termed the good cholesterol. We have LDL, or low density lipoprotein, that's often termed the bad cholesterol. From this, there is a calculated cholesterol to HDL ratio. So this is the total cholesterol divided by HDL. And the ratio is given here. Mine was 1.7, which is quite low. From the data, though, you can also calculate a triglyceride to HDL ratio, which is useful. And it's useful to order, and in some contexts, you can order other markers like ApoB or Lp(a). Right? But typically the lipid panel consists of total cholesterol, HDL, LDL, and triglycerides. It also says non-HDL cholesterol, so it kind of looks at everything besides the HDL, which is, again, a calculation of total minus HDL. And it also gives you a cholesterol to HDL ratio. So the test is usually fasting, because after eating, triglycerides will rise, especially if you've eaten fat. And so fat via chylomicrons enters the bloodstream. So fasting just gives you a more stable baseline, better comparison over time. Some guidelines allow non-fasting panels, but I almost always tell patients to fast for a cholesterol panel because you get more accurate triglyceride readings and a better triglyceride to HDL ratio. And very often people come in, they haven't fasted, their triglycerides are high or borderline high, and then they're often told to fast and repeat. So you might as well just fast and to get an established baseline. So let's start off with total cholesterol. So total cholesterol, right, is the sum of all cholesterol in your blood. And obviously alone, it's not very useful because if the total is high, that means something else like LDL or HDL or triglycerides are high, right? You know, what is high if you're looking at everything? You know, I often actually will find that total cholesterol can be too low in patients. And so although this is rarely ever flagged conventionally in the conventional system, when I see a total cholesterol of under 4 millimoles per liter, I start to get a bit concerned, and we often talk about raising dietary fat or recommending a phospholipid like oh my gosh, what is it called? Phosphatidylcholine or phosphatidylserine, something that can help to support cell membranes, brain function, serotonin signaling. Very often in vegan patients, I might see low cholesterol. I might see low cholesterol in people that are undernourishing, even if they don't really know that they are. They're not necessarily aware that they're not eating enough. And and I often see it in patients with anxiety, depression, sometimes hormonal issues, right? You need cholesterol to make hormones. So, looking at cholesterol can be really helpful, even if you're not necessarily looking at looking at it for cardiovascular disease risk. If you have very low risk for cardiovascular disease and you're not concerned about this point in your life. That's really all we have to say about total. Total is often the thing that's flagged, right? When it's over, it's about when it's over 5.2 millimoles per liter, it's often flagged as high. And sometimes that means that LDL is high. And so that's where you want to do more investigation. But very often it's just high on its own. And that doesn't really tell us much. Or, in the context of an overall healthy person, it's not that concerning. So HDL is our good cholesterol. It stands for high density lipoprotein. And its job is to remove cholesterol from the arteries. So it reduces the risk of plaque formation, heart attack, and stroke, because ultimately it's cleaning up the arteries. HDL is also a marker of metabolic health. It reflects insulin sensitivity and healthy lifestyle habits like physical activity. It is generally a good marker of metabolic health. Therefore, the higher the HDL, the better. Because it correlates strongly with insulin sensitivity, with lower inflammation, and with healthier lipid transport dynamics. So more lipids are coming out of the blood vessels and back to the liver. The HDL particles, they participate in reverse cholesterol transport. So they help move cholesterol out of peripheral tissues and back to the liver for processing and for excretion. And we often see higher HDL levels in people who exercise regularly, have lower visceral fat, have good insulin sensitivity, have lower systemic inflammation, and who are generally overall more metabolically healthy. So we want to look for an HDL level of over 1.3 millimoles per liter. Millimoles per liter is the standard international units that we use in Canada. In the US, you can do conversion calculators to find out. It's usually measured in milligrams per deciliter. I don't know off the top of my head how to convert the units. I usually have to Google or put them in a conversion tracker or conversion calculator. And certainly, the higher the better. You want your HDL to be at least 1.3 millimoles per liter. And so the relationship between insulin sensitivity and HDL, sort of the higher the HDL, the more insulin sensitive you are. Insulin sensitivity is the opposite of insulin resistance, right? Where you're not responding to insulin, you're gaining more weight, you're kind of on the spectrum of type 2 diabetes. Because when insulin sensitivity is good, the liver produces fewer triglyceride-rich particles, or VLDL, which stands for very low-density lipoprotein. And HDL particles stay in circulation longer. They don't get broken down. But in insulin-resistant states, HDL tends to drop because triglyceride exchange and liver enzyme activity can alter HDL structure and accelerate its clearance from the body, so it can lower HDL levels. So low HDL is often a marker of metabolic dysfunction. It's not a direct cause of disease. So it's something that we look at, but as a marker. Sometimes you see HDL lower quite quickly if someone's losing weight, like if they're on a weight loss plan and they're intentionally losing weight, and maybe that weight loss is happening kind of quickly. You might see HDL temporarily dip below normal range, and then it comes up and normalizes typically once someone is stable or plateauing or more in a maintenance phase of their journey. But whenever we start to see low HDL, we definitely want to test a fasting insulin, fasting glucose, and get a HOMA-IR score, which looks at insulin resistance. So when you have total cholesterol and HDL, you can calculate a cholesterol to HDL ratio. And this is often given in a cholesterol panel. So Life Labs will give you your chol to HDL ratio. But you can calculate it yourself by taking your total cholesterol and dividing it by the HDL number. And so you ideally want the number to be under 3.5, acceptable under 5, that's a bit high. And the higher it is, the riskier, the more risk is present. The purpose of this ratio is to give context to total cholesterol, because total cholesterol alone doesn't distinguish between good and bad or atherogenic cholesterol. And so by dividing the number by HDL, the ratio reflects how much cholesterol is being carried relative to the amount involved in reverse cholesterol transport. So how much is being taken away from the arteries and being brought back to the liver, essentially. And there's lots of studies that show that this number is in many ways more important than total cholesterol. So triglycerides are really interesting. And often when people are told they have high cholesterol, it's their triglycerides that are high. And this is a completely different story than if their LDL is high. And I see this confusion in my practice constantly. And it's part of the reason why I wanted to make this video. Because patients will say, I got my blood tested and my doctor called me and said my cholesterol's high and I'm really worried about it. And my first question is always like, well, what part is high? They're like, I don't know. Some are even prescribed statins for high triglycerides. So let's talk about it. So triglycerides are a storage form of fat in the blood. They are strongly influenced by sugar intake, refined carbohydrates, alcohol, insulin resistance. They are a strong marker of metabolic stress, particularly related to insulin resistance. They are stored fat in the bloodstream, as we said, and they're primarily carried in very low density lipoproteins, so VLDLs, that are produced by the liver, and these particles are atherogenic. So triglycerides tend to rise when our carbohydrate intake exceeds our metabolic capacity. Right, so this is the same process that drives insulin resistance, or one of the processes that drives insulin resistance. When insulin levels are chronically elevated, we tend to have higher triglycerides. There's a whole process involved in this. When fat cells and liver cells are insulin resistant, they tend to put more triglycerides out into the blood. When there's hepatic insulin resistance, you get more triglycerides in the blood. When there's an increase in novolipogenesis, so you're converting excess glucose into fat in the liver. So triglycerides are also a signal for non-alcoholic fatty liver disease, or NAFLD. When alcohol intake is too high, possibly because the liver is having trouble prioritizing and so sends more triglycerides into the blood. And in insulin-resistant states, as we talked about, the liver overproduces VLDL particles. These are loaded with triglycerides. And these triglyceride-rich particles circulate longer. And they also lower HDL. And they also create smaller, denser LDL particles, which are not great for heart disease risk. Elevated triglycerides are therefore a reflection of impaired metabolic handling of energy, particularly carbohydrates, more than fat. And so often if you're told you have high cholesterol, but the main abnormality is high triglycerides, then the clinical issue is actually metabolic, not necessarily LDL-driven atherosclerotic risk. And this is important because statins, right, the first line treatment for lowering cholesterol, they primarily lower LDL cholesterol, and more importantly, the ApoB particle number. They only have a modest effect on triglycerides, so typically about 10 to 30% reduction. And so if your LDL and ApoB are normal, and the primary issue is high triglycerides, then the first line approach is more appropriately about focusing on the liver, so reducing fatty liver, looking at what might be causing that, and addressing metabolic drivers. So getting insulin down, definitely you want to measure a fasting insulin in this case, and looking at improving metabolic health rather than immediately going to a statin. And certainly, being told to be on a low-fat diet is not going to be the right answer. It's more about carbohydrate intake and liver health than it is about eating too much like coconut oil or something. So you want your triglycerides to be under 1.7 millimoles per liter, ideally even lower. So, kind of more naturopathic ranges would be under 0.8 millimoles per liter. And remember that elevated triglycerides primarily reflect impaired metabolic handling of energy, particularly carbohydrates, and they're only modestly lowered by statins. And so the standard recommendations, right? So this is so important because when you get a phone call or you're told your cholesterol's high, you see your total cholesterol's high and you see triglycerides are high. And you don't really know what that means, but you're scared. And maybe your doctor even is saying, oh, well, you can go on statins, like watch your fat intake, don't eat eggs. So the standard recommendations for lowering cholesterol, like going on a low fat diet, can be quite misleading if your triglycerides are high because they're not typically driven by dietary fat intake. They are more strongly influenced by excess carbohydrate starch, particularly intake, and refined sugars, but mostly by chronically elevated insulin levels, right? And we can get insulin resistance from stress, sleep deprivation, intense stress, like high cortisol can influence that. Certainly, perimenopause and menopause increases our risk of insulin resistance without any necessary lifestyle changes. We can see more insulin resistance, sedentary lifestyle, low muscle mass. So it's not strictly diet, but diet is a big lever that you can move when it comes to insulin resistance. So for someone with high triglycerides, evidence-based first-line interventions include reducing refined carbohydrates and added sugars, so increasing your fiber, more fruits and vegetables as carbohydrate sources, less starches, especially refined starches, flours, sugar, limiting or eliminating alcohol, limiting or eliminating alcohol, increasing your protein intake, which manages the glycemic index of your meals, increasing soluble fiber. This is fiber found in psyllium, chia, flax. Weight loss if visceral adiposity, so visceral fat is present. Managing fatty liver, so maybe running a panel where you look at your liver enzymes. Maybe an abdominal ultrasound to visualize fatty liver. Strength training, regular aerobic activity, improving sleep and reducing chronic stress. And in many cases, triglycerides can respond quite quickly, often within a few weeks to months, when we address diet, lifestyle focused on insulin resistance and improving insulin levels. So definitely, if triglycerides are high, you want to advocate for a fasting insulin. Great and really important if you get it along with a fasting glucose. And a hemoglobin A1C, so you can look at different factors that are involved in your metabolic health. Liver enzymes would be really important too. Although not everyone with elevated triglycerides and fatty liver have elevated liver enzymes, it's another piece of the puzzle that we want to investigate. So you can also, now that you have your HDL level and your triglycerides, you can calculate the triglyceride to HDL ratio. It's a simple way to estimate your metabolic health and your insulin sensitivity using just a standard lipid panel. So if you don't yet have a fasting insulin, you can kind of gauge your insulin sensitivity by doing this panel. Because triglycerides rise when the liver is overproducing fat in response to excess sugar or starch intake, when there's high insulin or insulin resistance. And HDL tends to fall in those same states. So this thing happens where triglycerides go up and HDL goes down in the presence of metabolic dysfunction. And so this combination of high triglycerides, low HDL reflects an impaired metabolic regulation and hepatic insulin resistance. And this is something that you would like to know about if it's happening. And so basically, mechanistically, as we learned, the liver increases VLDL particles. These are high in triglycerides, and these interact with HDL via a protein that you don't need to know and exchanges triglycerides for cholesterol. And so HDL becomes triglyceride enriched, and then it's cleared more rapidly from circulation. So this lowers it. So triglyceride to HDL ratio correlates very well or reasonably well with insulin resistance. So elevated fasting insulin, metabolic syndrome, increased risk of type 2 diabetes, and higher cardiovascular risk, because we know it's not just about cholesterol, it's also about the whole context of your metabolic health, right? Because we know that the more inflammation in your body, the more likely there's endothelial injury that's going to start the whole cascade of atherogenesis. So in millimoles that we use in Canada, we want to have a triglyceride to HDL ratio under 1. So you can get this by taking the number of triglycerides and dividing by the HDL number. So you want that number to be under 1, acceptable under 2, above 2 starts suggesting that there may be an increased insulin resistance. And in the US units that use milligrams per deciliter, you want to be under 2, and above 3 suggests insulin resistance. So it's important that this is not a diagnostic tool in and of itself. It's not telling you if you have insulin resistance, but it's a useful screening marker. And it's something that you can do essentially for free if you already have a lipid panel, right? So you don't have to order any additional tests to get this number. You can do it right now if you have your cholesterol panel in front of you. In fact, I could do it right now. My number would be under 1, for sure. Would be very low, actually. But I was responding really well to this diet at the time. It just wasn't a sustainable diet. It was a ketogenic. It was a kind of experiment I was doing. I was having a lot of coconut, a lot of avocado, like a lot of fats in my diet, and very low carbohydrates. And I don't eat that way right now. So a low triglyceride to HDL ratio generally reflects that there's efficient energy handling, good insulin sensitivity, and lower cardiometabolic risk. And a high ratio suggests that there's some sort of metabolic stress, especially related to excess carbohydrate load, visceral fat, alcohol intake, or possibly a sedentary lifestyle. So all of these are modifiable factors and conditions that you can work with, which makes it a very useful tool. And of course, you want to interpret it alongside other markers like fasting glucose, fasting insulin, waist circumference, where you measure either at your belly button, the smallest part of your waist, blood pressure, and of course, ApoB. Okay, and as we learned, this ratio looks at insulin sensitivity, liver fat, carbohydrate tolerance, and the key message is that you might have high LDL, but low triglycerides and high HDL. And this might actually mean that you have a very low actual cardiovascular risk. So we'll talk about that. So it adds context to the whole picture. So LDL is your low density lipoprotein, or your bad cholesterol. And it's bad because it tends to be more atherogenic. It delivers cholesterol to the tissues. So you need it because it allows cholesterol to do all the things that it does, but it can contribute to plaque formation in certain contexts. So on the one side, there's consistent evidence that ApoB containing particles, which is sort of an umbrella term that includes LDL particles, are causally involved in atherosclerosis. So there's all types of different data and studies to show this. They show that the higher lifetime exposure to LDL particles increases the risk of plaque formation, of heart attack, and of stroke. And lowering LDL particle burden reduces cardiovascular events, especially in higher risk individuals. So from that standpoint, you need LDL particles to form plaques. You don't have plaque formation because you have high LDL. There's a correlation there, but you need them to create plaques. Without ApoB particles, like LDL entering the arterial wall, atherosclerosis does not occur. But on the other side of it, there's some controversy and some nuance to this number, right? So if your doctor calls you and says you have high cholesterol and you see your total cholesterol is high, and then you look at your cholesterol panel and then you find your LDL is high. So usually that's over 3.5 millimoles per liter. But that it also depends based on other risk factors. So it's not the same number for everyone. So what the cholesterol panel though is measuring is LDL-C. So the cholesterol content inside the LDL particles. And it's not the same as LDL particle number. So this means that two people can have the same LDL-C, but very different numbers of particles. So think about it as like people on the highway. If you have a lot of buses on the highway, you've got less vehicles, but the same amount of people as if you had every single person driving in their own car, right? There's going to be more traffic. So you may have a lot of LDL cholesterol, but it's packaged into bigger LDL particles, and you don't have as many LDL particles. So risk appears to track more closely with the particle number, which we can measure by looking at ApoB, than by the total amount of LDL cholesterol. So when you're told that your LDL is high, this what that means can vary biologically. And of course, context matters, right? Because LDL doesn't cause plaque in isolation. Atherosclerosis develops in the presence of endothelial injury, right? The injury to the lining of your blood vessels. Inflammation, oxidative stress, possibly caused by smoking or stress, hypertension, diabetes, or insulin resistance. That brings us back to the triglyceride HDL conversation. Someone with elevated LDL but low triglycerides, high HDL, low inflammation, normal blood pressure, and no diabetes has a different absolute risk than somebody with elevated LDL plus the reverse of all those things, plus metabolic syndrome and other risk factors. Age, biological sex, these are other risk factors. Third, diet patterns complicate the interpretation. So some people on low carbohydrate or ketogenic diets, they may develop higher LDL-C, but they still have low triglycerides, high HDL, low insulin, and improved metabolic markers. And they may actually have low particle number. And so we actually don't know the long-term risk implications of these individuals. We're still studying them. So it's not true for someone who feels great on the ketogenic diet to be like, there's no who gets high LDL. So you can see there's some people that will get their LDL will go up in response to healthy saturated fats like coconut oil. My cholesterol doesn't tend to do that. Actually, my LDL goes down, my HDL goes way up when I'm having more saturated fat. But some people will notice a massive increase in LDL, and we don't really know the risk on those individuals, because those same individuals may have lower inflammation, lower insulin, they feel great, and then they say, well, it doesn't matter what my LDL is. And we just don't have the data that tells us for certain that that's true. But their metabolic context is obviously very different from somebody who has high LDL, but also high triglycerides, high ApoB, high inflammation, smokes, and all of that. So risk is also cumulative and age dependent because LDL exposure over decades matters more than one lab result. So the first time your doctor calls you, it's typical, unless your LDL is extremely high and you haven't had your blood tested in a while. If you've had it tested every year and this year you're seeing it's like slightly above the number and you don't have an increase in other major risk factors, then, it's typically not an emergency situation where you need an immediate response, because it's more about the exposure over decades more than that singular lab result. So younger people with modest LDL elevations and no other risk factors, they have a lower short-term risk, but they may have a higher lifetime risk if their LDL remains elevated over time. You could think of about that kind of logically, like the more LDL that's circulating over the years and decades, the more chance it's going to start to form plaques and the more time it has to form plaques. So, LDLs become the focus, right? It's the bad cholesterol. It's the number we want to lower. Statin medications lower that number most effectively. And this creates that LDL is bad message. And that's also the emoji thing that I included on the slide with this devil pitchfork caricature of LDL cholesterol, and the HDL is an angel, right? And so this is obviously not super accurate binary. The more precise statement is higher concentrations of ApoB containing particles increase the probability of atherosclerotic plaque formation over time. And that's like less of a slogan that you can transmit easily. And so you might want to write that down, right? So it's really higher concentrations of ApoB containing particles over time increase the probability of atherosclerotic plaque formation over time. The controversy is not about whether LDL participates in atherosclerosis, right? This is well established, but the debate centers on how much LDL is too much, when should we intervene with medication, how does the particle number, how should that number be interpreted, how does your metabolic context modify your risk, who benefits the most from medication, how aggressively should you treat low-risk individuals, right? So should we scare you by saying you got to get your cholesterol down, or can we tell you like you're okay? Like, just give you more information about your overall risk and the context that you're in. And in short, LDL is not a toxin. It's a necessary lipoprotein that becomes pathogenic when particle numbers are high and the vascular environment is susceptible. And so the clinical question is always about absolute cardiovascular risk, not just LDL in isolation. If you also think about this, right? We don't really, there's nothing bad in and of itself about higher or even really high LDL. The problem is cardiovascular disease risk. And even then, the actual problem is heart attack and stroke. And even then, the actual problem we want to avoid is death from an injury from heart attack and stroke, right? So we're looking at the relationship of LDL to those outcomes that we don't want. And that's what we care about. Okay, so by lowering LDL, we're lowering the risk of having those outcomes. So the key message of your cholesterol panel is that triglycerides tell you more about your diet and metabolism than just LDL. Lipoproteins like HDL and LDL are transport particles. They allow fat to move through the bloodstream. LDL moves that fat in its particles or cholesterol to blood vessels, and HDL moves it away from blood vessels to the liver. Risk relates primarily to the number of atherogenic particles, which are ApoB containing particles such as LDL and VLDL that are in circulation, not to cholesterol as a molecule in isolation. So ApoB, I keep saying this, right? It stands for apolipoprotein B. And ApoB is a really important marker, but it's, in my opinion, not tested enough. It is found on every atherogenic particle. So it's found on LDL, so the particles, right? You have your LDL cholesterol that you have this number here in your cholesterol panel. Your LDL is packaged into a number of particles, and the ApoB number signals how many of those particles you have. So it's found on LDL particles, VLDL or very low density lipoprotein particles, and IDL or intermediate density lipoprotein particles. So the nomenclature is very creative: low density, high density, intermediate density, very low density lipoprotein. These are atherogenic particles. So these are the particles that are involved in plaque formation. And the research shows it's more about the number of particles than it is about the total cholesterol within those particles, right? Like a traffic jam is going to be more related to how many cars are on the highway than how many people are on the highway, because those people could be in buses or trains or, low volume vesicles or vehicles. So ApoB represents the number of particles, and it's the number of particles that we care about, the number of bad particles. And it matters because plaque is driven by particle number, not just cholesterol content. So it's a better predictor of cardiovascular risk than LDL alone. So if you've been told that you have high cholesterol, and then you look at your cholesterol panel and you see, okay, yeah, the total cholesterol is high. What does that mean? Not a whole lot. Oh, my LDL is high. Okay, what does that mean? Oh, now I'm scared, and my doctor maybe wants me on a statin or is telling me to stop eating eggs. And unless there's a ton of risk factors, and we have to act quickly, it is very important, in my opinion, to check your ApoB. So, and this is especially important if you're already on a healthy diet, you don't smoke, and you exercise, and you want to know more about what that high LDL number actually means. Because this is going to tell you more about your cardiovascular disease risk than just the LDL number, especially if you're healthy. So ApoB is not routinely measured in everyone with high LDL, and it's just often for practical reasons, historical reasons, but not because it lacks value. So it's kind of it's not a new marker, but it's like one that more people are paying attention to and advocating for. And it's something that you can advocate for with your, a naturopathic doctor can order it for you, and you can also advocate for it with your primary healthcare team. And of course, it's up to your doctor to decide whether to order it for you, but this would be helpful to see. And so the reason we don't measure ApoB as much is because most lipid guidelines were just built on decades of just using LDL cholesterol, so LDL-C, total cholesterol, so number of people on the highway, not ApoB. And the large statin trials that shaped cardiovascular policy They're primarily tracking LDL-C reductions and cardiovascular outcomes. So they kind of skip ApoB altogether, which is fine for big population-wide studies, right? Because you see a reduction in LDL, so you see a reduction in cardiovascular outcomes. So that's fine. But when you start looking at the individual, this is where ApoB becomes really helpful. But LDL-C, because of this, became the standard marker embedded in clinical practice, in insurance coverage, and in lab panels. And LDL, right, in a total cholesterol panel, it's inexpensive, it's widely available, standardized, easy to calculate. ApoB is not that expensive, but it's it costs more than the entire cholesterol panel. It requires a separate assay. It's not difficult to measure it. It's just part of a blood test that you get it measured the same way you get your cholesterol measured. But it adds cost, and it's not automatically included unless you advocate or ask for it. And sometimes you may not be reimbursed for it. And some doctors, I've heard different things. One told my patient that they weren't allowed to order ApoB and a cholesterol panel at the same time. I don't know exactly what they're referring to or what guideline that's from or what communication they were given. But I've heard different things. So you may have to pay for it out of pocket, or your naturopathic doctor could pay for it for you. So ApoB is biologically more precise, right? And this matters on the individual level, And so every atherogenic lipoprotein particle, LDL, VLDL, IDL, or Lp(a), which we'll talk about, carries one ApoB molecule. So ApoB directly reflects the total number of atherogenic particles in circulation. So this is ultimately the number that you should care the most about. If you see that ApoB is high, now you've got to start thinking about lowering that number, lowering your LDL. So two people can have the same LDL-C number, but different ApoB numbers. Okay, so as we saw in my cholesterol panel, I didn't have high LDL from the ketogenic diet, but if I had, I would want to measure my ApoB, and I'd want to see if that number was high. And I may have the same high LDL level as someone else. They have high ApoB and I might not. And so one of us has to worry more about lowering our cholesterol, and the other one may not. So it matters to measure ApoB because some people have fewer cholesterol-rich LDL particles. They have larger particles, and others have smaller particles. And there is some thought that we tend to make larger particles, so they're better at packaging cholesterol when we're getting a rise in LDL from like healthy fats, healthy saturated fats. So some people who are on a ketogenic diet and they're doing it like a good keto diet, or they're exercising and their LDL goes up, often may have an increased LDL size and lower ApoB. So LDL-C, to put it a different way, measures cholesterol mass. ApoB measures particle count. And risk appears to track more closely with particle number. So should you measure your ApoB if you have high LDL? I think yes. And arguments in favor are because it clarifies the risk when LDL-C and triglycerides are discordant, meaning you have high LDL and maybe low triglycerides. It helps people with metabolic syndrome or insulin resistance understand their risk. It provides better precision for treatment decisions. It gives you more knowledge about what the LDL number means, right? Is it bigger particles? Is it smaller particles? And many guidelines, including Canadian and European guidelines, now recognize ApoB as an acceptable or even preferred target in certain populations. And arguments against universal measurement are arguments that are more applicable in public healthcare or universal healthcare settings. Because LDL-C and ApoB are closely related, and in certain individuals who are clearly high risk, you may not need to measure ApoB because you're just measuring the same thing twice. Cost and access. So ApoB is more expensive for the healthcare system or for the individual who's paying out of pocket. But it may be particularly useful when your LDL-C is moderately elevated, but your triglycerides are also elevated. There's metabolic syndrome. There's uncertainty about whether to start medication. Risk appears borderline. Patients want more specific information about their risk and their LDL level. And it adds most value, I think, in intermediate risk situations where decision-making is not obvious. So maybe patients are, they're not that thrilled to go on a statin. They're not sure if they need one, but maybe their doctor's pushing for one. So it's useful for us to measure ApoB. Then we can tell them more definitively if a statin is appropriate, like what the other options are, how important it is to really care about lowering LDL. So again, right, we're looking at, it's not just when we're looking at a cholesterol panel, you've got the total cholesterol. We might be alarmed by that number, but that number doesn't tell us much without more context. And we want to see low triglycerides, high HDL, and we want to see LDL within the normal range. If we start to see difference, so we see low HDL and high triglycerides, this is pointing to more metabolic syndrome or insulin resistance conditions. If we start to see high LDL, what I would want to understand is how many LDL particles are there, how many atherogenic particles are in the person's bloodstream, as opposed to the total amount of LDL cholesterol in their blood, which would point more to their individual cardiovascular risk. And of course, we want to know what your insulin is, what your fasting glucose is, what your inflammatory markers are, if you smoke, your lifestyle practices, your sleep, digestion, how you feel generally in your body. Do you have a lot of joint pain? Do you have a lot of brain fog? Are you fatigued? Do you have nutrient deficiencies? There's so much to unpack and to look at. It's, rather than just like your cholesterol is high. So Lp(a) is another marker that's worth talking about. It's a genetically determined lipoprotein. It's not responsive to diet, and it's elevated. When it's elevated, it can increase cardiovascular risk. So you could think of it as like kind of a separate marker that could be tested once in your life, and it's a genetically determined marker. So if you have high Lp(a), there's a higher risk that you have cardiovascular disease. It doesn't necessarily interact with the rest of your cholesterol panel, but it adds more context to that cholesterol panel. So if your LDL is high, if your ApoB is high, even if your triglycerides are high, it's giving us more context that your overall risk of cardiovascular disease is probably higher. And so this is going to guide treatment and how seriously we take even like a moderately elevated LDL. So often when you have this marker, you may have a family history of early heart attack, stroke, high cholesterol. Again, you really just need to test this once in your life because it's not very modifiable. So it's kind of like it's like when you do a genetic test. It can influence how you approach your health based on some risk factors that you have. It's an independent, genetically determined risk for atherosclerotic cardiovascular disease, and it's largely genetic and not very responsive to lifestyle, but it helps you understand your overall risk. It's structurally similar to LDL, but it has an additional apolipoprotein, the little a attached to it, and the extra component makes it more atherogenic and more thrombogenic. So it's this extra particle in the blood that's problematic and can promote plaque formation and increase clotting risk. So it's just good to know that that's there so you can reduce your overall risk around it, and possibly take your risk more seriously. Because it's associated with a higher risk of premature heart attack, ischemic stroke, aortic valve stenosis. And because it's genetically determined, it remains relatively stable throughout your life. And so most guidelines recommend just measuring it once, especially if you have a family history of early cardiovascular disease, unexplained high LDL, a personal history of premature cardiovascular events, or borderline or intermediate calculated risk. And the point of measuring it is just to like stratify or understand your risk, right? So if you have high Lp(a), then your lifetime cardiovascular risk may be higher than standard risk calculators suggest. And so this may influence your personal health decisions or the decisions that you come to with your doctor about how aggressively you should lower your LDL or ApoB, right? Do you want to kind of try lifestyle for a few months, or do we need to maybe add a statin or something that's going to lower your cholesterol? Do we add the statin in right away? How tightly do you need to control your blood pressure? How intensively should you be addressing lifestyle factors? And statins don't meaningfully reduce Lp(a). They may even slightly increase it, but statins will reduce your overall cholesterol risk, right? Because they're lowering ApoB particle numbers. So they're lowering like a different risk factor to lower your overall risk, if that makes sense. So reducing your total atherogenic burden, right? And there are some therapies that can lower Lp(a) modestly. But yeah, it's basically telling us more information about your overall risk to help guide your risk assessment and the intensity of management. Familial hypercholesterolemia is a separate condition from Lp(a). So Lp(a) will increase your risk factor. Familial hypercholesterolemia is a genetic condition where LDL tends to be high from a young age. So it's separate from you may not have Lp(a) and have familial hypercholesterolemia. It is defined by an LDL of over 4.9 millimoles per liter or 190 milligrams per deciliter, and an early family history of heart attacks and stroke before age 55 for men or age 65 for women. And it's not just lifestyle related. It often requires additional support. So maybe medication, or sometimes I have patients on supplements that lower and keep their LDL in normal range plus lifestyle. We do, I have a few patients with familial hypercholesterolemias. They just have high LDL and high total cholesterol. And we really work on education and understanding their risk. And we talk about their values and what they would like to do. And some opt for low dose statins, but they really can manage their total cholesterol with, diet and exercise and stress management and all kinds of things. If you have this, you're not doomed, but untreated, your cardiovascular risk can be significantly higher. And very often when we talk about family history with patients who have this, they'll talk about how, maybe their parent had a heart attack at a very young age in their 40s or 50s, but that parent also maybe smoked, drank a lot of alcohol. So there's often extra risk factors in combination with this genetic condition that are hard to tease apart. So it's hard to really know somebody's individual risk when they have this. And so we do a lot of talking. We do a lot of teasing out concepts. We measure insulin. We make sure that they're metabolically healthy, inflammation is low, that their nutrient levels are good. So FH, or familial hypercholesterolemia, is a genetic condition. It causes elevated LDL particles from birth, usually. And it's usually due to impaired LDL receptor function. So it causes an accumulation of ApoB containing particles over decades in the arteries. And atherosclerosis is partly a function of both the particle number and how long those are in circulation. So lifetime exposure matters. So before, we had more treatment, FH was associated with substantially increased risk of premature heart attack, sometimes in the 30s and 50s. But that's often a historical risk before statins and other medications and routine screening and early intervention. So now the outcomes are very different when it's diagnosed early and treated appropriately and combined with lifestyle risk reduction. And sometimes aggressive LDL lowering. It can significantly reduce cardiovascular event rates. And the goal is to reduce cumulative ApoB exposure over time. So those who have FH and receive early treatment often live normal lifespans. And then there's different kind of genetic factors for this. And lifestyle matters a lot in FH. It's often not enough to bring LDL into the normal range because the underlying issue is genetic LDL clearance. So even if you're, reducing your LDL, helping to clear it, it's hard to overcome the slowness of clearance by the body. And so sometimes even a low dose, like a baby dose of a statin, could be helpful. And so the key message of familial hypercholesterolemia is that it increases your risk, but risk is often modifiable. In this case, it is. And early diagnosis, appropriate LDL lowering, blood pressure control, avoidance of smoking, and overall metabolic health can substantially change the trajectory. So think of it as a risk amplifier, but not a predetermined outcome. So this picture, high LDL in a metabolically healthy person, fits a lot of the patients in my practice. I mean, It's kind of a selected sample because they're seeing a naturopath, they care about their health, they've, socioeconomic status, all types of different factors. So often when patients end up with finding that they have high LDL, they're often metabolically healthy, or we've been working, or we talk about metabolic health. So we're bringing that into the conversation and into the treatment plan. But sometimes patients will come in, and this might be you as you're looking at your cholesterol panel right now, where you have high LDL, but you have low triglycerides or good triglycerides. You have high HDL or good HDL. You have low inflammation. So your inflammatory markers like high sensitivity C-reactive protein or CRP is low. You have an active lifestyle. You're a healthy body weight. Your insulin levels are good. Your HOMA-IR is good. Your triglyceride to HDL ratio is good. But you randomly have high LDL. So possibly it could be genetic. It could be a low carb or ketogenic diet where you're just eating more fat in lieu of carbohydrates for energy. And so your LDL may come up. So it's important you want to measure ApoB in that case. You possibly could be in a weight loss phase where more fat is being liberated into the bloodstream. So you want to look at the whole context, right? LDL doesn't just exist on its own. You want to look at your triglycerides, your HDL ratio, your ApoB, your hsCRP, your insulin or HOMA-IR. And when your LDL is elevated, but your triglycerides are low and HDL is high, this is a more nuanced situation because it's a pattern that reflects good insulin sensitivity and favorable metabolic health, right? So these are all risk factors for cardiovascular disease. And so what we want to understand is, do you have a high number of LDL particles, first of all? And so we want to measure ApoB in this situation. And then we want to talk about it, right? Like, is this something that's truly concerning? What is your actual risk? How old are you? All of these different things. So if we see this, right, if this is you, the first step I might recommend is to measure your ApoB. Let's get some more information. Let's find out if we actually should be worried about this LDL number or if this is just the total amount of LDL cholesterol and your actual particle number is low. So maybe you have big, buoyant, large LDL particles and you don't have a lot of them. So your risk of atherogenesis is low. If your ApoB is normal, it means that the total number of atherogenic particles is not elevated, even if your LDL-C looks high. And in that case, cardiovascular risk may not be meaningfully increased, especially if your other risk factors are favorable. Like you have normal blood pressure, you have no diabetes, you have low inflammation, you don't smoke, and you are active. And so management may just mean that we just monitor it over time. If ApoB is elevated, and then that means that your particle number is high, and that does represent an increased atherosclerotic risk, regardless of your triglyceride level, right? So even though you have these other factors that are lower, that's still good, but we should care and try to lower your ApoB number. So the next step is that we're looking at your global cardiovascular risk. So when we're sitting down, our intakes with a naturopathic doctor is usually 90 minutes. My follow-ups are 60 minutes. Rarely I'll do half an hour. And this is because your story matters when it comes to health. Like you can't get to the bottom of complex, like metabolic health, hormonal health, mental health. These are multifactorial conditions, and they require a relationship with the provider, a practitioner, where I can listen to you, I can understand your story. And then even if we're talking about lifestyle changes, I mean, it's not as simple as just telling you what to eat and not to eat. I mean, we've been told that our whole lives, It's about the conversation. It's about, the motivational interview. It's about, solution-focused interventions to understand, like, what's going to work for you. What do you want to try? What makes sense to put your energy into? When should we measure? When should we follow up? This is like a whole conversation that we have. And in this conversation, we want to look at all these factors that could determine or can influence your overall cardiometabolic risk, right? Your age for sure, right? Because this is going to increase risk, but also it may indicate the longer you've had higher LDL in circulation. Your family history, your blood pressure, your smoking status, And there we might want to work on smoking cessation or helping with lung repair or supporting antioxidant status, fasting glucose and insulin resistance markers, inflammation. And these are all separate treatment angles, right? That don't just involve like pushing cholesterol down or focusing on getting the cholesterol number down, right? Even with medication, we want to look at like, how do we reduce your overall risk by lowering inflammation? And then the great thing is that you get rather than side effects, you get side benefits. You feel better generally. We want to look at your Lp(a) if it hasn't been tested. Possibly a coronary artery calcium score in intermediate risk. And, management is going to depend on absolute risk. So we might say, let's just continue with a healthy lifestyle, and then we'll recheck in 6 to 12 months. If your ApoB is low, and we may not say, okay, there's not really an immediate need for medication in this case. But if ApoB is elevated, and overall risk is still low, we may also just start with lifestyle and focus on that first. And then we might just retest in 3 to 6 months. So 3 to 6 months, if we're trying to lower ApoB, is a reasonable time to repeat a test. And, with a naturopathic practice, with a collaborative biopsychosocial style practice, aka a holistic practice, individualized medicine, it's shared decision-making, right? So my job is to convey information to you, offer all the information that you need to make an informed decision. And then we have a conversation and we make a decision together and we talk about long-term strategy. Like we work together, we brainstorm on how to move forward. If ApoB is elevated and your overall risk is moderate to high, so you have like a strong family history, elevated Lp(a), hypertension, diabetes, evidence of plaque, then we might talk about, more aggressively or a more focused approach to lowering LDL, and that often will be statin medication. Statins are the first line treatment for this. The goal is to reduce the cumulative particle exposure over time. So even in metabolically healthy individuals, persistently elevated ApoB can still contribute to plaque formation. So I hope that came across in this lecture. So even if you have good triglycerides and high HDL, it doesn't completely neutralize the high particle burden. So the sequence when you have high LDL and nothing else is to confirm particle number with ApoB, evaluate your total risk, decide on the intensity of intervention based on absolute risk, but also patient preference, right? Many of my patients don't want to be on a statin, and that's fair enough. And so we try. And, with a focused intervention, we can often lower ApoB really effectively. And management is individualized, right? So elevated LDL in isolation does not automatically mean you have to go on a medication, even if it's being kind of pushed on you or you're feeling a bit of pressure. But elevated ApoB with additional risk factors kind of warrants more aggressive prevention. So we may talk about that together if you were my patient. So when should you consider a statin? Well, you could just, as soon as it's being recommended by your general practitioner, you can just start one if they recommend it and if that's your preference. They work by reducing the liver's production of cholesterol and increasing the liver's ability to remove LDL particles from the bloodstream. And so they inhibit an enzyme called HMG-CoA reductase. And the enzyme is a key step in the cholesterol synthesis pathway. When it's blocked, the liver makes less cholesterol. So you block HMG-CoA reductase and you don't make as much cholesterol. And so actually the liver then responds by increasing LDL receptor expression. And so you get more LDL pulled out of circulation. So more LDL particles are cleared and less are made. And so because each LDL particle carries one ApoB molecule, statins reduce LDL, so LDL-C and ApoB particle number. They also will slightly lower triglycerides and slightly possibly raise HDL. So their results, like the mechanism of statins, is that they lower circulating LDL cholesterol, they lower ApoB, they reduce atherogenic particle burden, they reduce risk of plaque progression and cardiovascular events, and they typically lower your LDL by about 20 to 60%, depending on the dose and the potency. They modestly lower triglycerides and they slightly raise HDL in some individuals. And sometimes people are put on doses, like it's always good to think about individualizing medication doses, because I've seen many patients come in who have been put on kind of the standard starting dose of a statin, and it is pushing their LDL quite low and their total cholesterol very low as well. So I am not the prescriber, but we often educate and talk about, like, you maybe don't need to be on this high of a dose to get your LDL into an optimal range. And if we are being more precise by measuring ApoB, that can really help us guide the dose. You can really tailor the dose to your individual needs. Statins also have secondary effects. So they reduce vascular inflammation, they improve endothelial function, they stabilize existing plaques, they make the plaques less likely to rupture. So these additional effects contribute to reduce risk of heart attack and stroke. So they don't eliminate cholesterol production entirely. You still make cholesterol, which you need for your brain, for your hormones. The cholesterol remains available for essential functions, but the goal is reducing excess circulating atherogenic particles, not eliminating cholesterol from the body. And actually, you could think about, if you have familial hypercholesterolemia, then statins are a pretty appropriate intervention, because it is essentially, it's not treating the root cause in the sense of the genetics. It's not treating the genetics, but it's quite close to a root cause treatment. So in that case, it's not, I have one patient I'm thinking of that we've been working with for many years, and she's very healthy. She's living her best life. She has familial hypercholesterolemia, and she actually is managing her LDL quite well. Her ApoB is slightly elevated, all of these things. And we were talking about, different interventions and evidence-based stacks of lifestyle and supplements to bring down her ApoB. And at one point she just asked me, like, what about just going on a statin? And it's like, fair enough, so maybe that, just one small pill, maybe even every second day. So statins are generally well tolerated, but like all medications, they have potential side effects. The likelihood and severity vary by individual dose and the specific statin that you use. Very common side effects are muscle symptoms, muscle aches or soreness, so myalgia, muscle stiffness or weakness. These are often like mild or reversible. And rhabdomyolysis, like a more severe form of this, like severe muscle injury, is relatively rare. You might see elevation in liver enzymes. You may see an increase in ALT or AST. Rare to have serious liver injury, but it can happen. And so you want to routinely monitor liver enzymes. You may see increased blood sugar. So may increase the risk of developing type 2 diabetes if you're already at risk. The absolute increase is small, and cardiovascular risk reduction generally outweighs this effect in higher risk patients. So it's a little bit of a paradoxical thing, right? If insulin resistance and type 2 diabetes and liver issues is a risk factor, you want to kind of balance things. One thing I learned when I was doing my pharmacology test, when naturopaths moved to a different regulatory college, one thing we learned, right, is that the dose, and this is, actually I didn't learn this then, but the dose makes the poison, right? So really side effects are largely dose dependent. And, often when studies are conducted on medications, you want to give people kind of a one size fits all dose that's going to work, right? So you're not going to kind of one by one tailor the dose to the minimal effective dose for each patient. But when you're working one-to-one with somebody who has time and attention, you can really do that. Or when you're your own doctor and you're working with your own body and you're understanding your cholesterol panel, you can, your doctor can give you a prescription for a statin. You can research the different types of statins and the different doses. You can see how that impacts your ApoB. Maybe start with a very low dose of it, see how that impacts your ApoB, and then go from there. And you may find that you just need a little dose to get your numbers in the right level, right? Not everybody requires the same dose of medication. So by understanding your cholesterol panel, by being able to talk to your doctor about it, you may not need to be on just like this one size fits all big dose. And I commonly see that dose is too high for a lot of patients, and that it's like it's overshooting their LDL is going way too low. Their total cholesterol is falling too low. So less common side effects are cognitive complaints, memory issues, brain fog. I wonder if these are patients who are pushing their cholesterol levels too low. The dose is way too high. Large trials have not consistently shown cognitive harm. One patient was aggressively told by their cardiologist that there's no evidence that statins cause cognitive dysfunction. But you need cholesterol for brain health. So you want to just be understanding your cholesterol panel and making sure that you're not overdoing things, that you're getting things in the normal range, understanding that it's not good to have too low cholesterol either, and understanding that's all nuanced. So again, statin side effects are dose dependent. Switching to a different one or lowering the dose can often resolve your symptoms, and you may not need to be on that much of a dose to get your ApoB in target. And, if you have high risk, then, the reduction of cardiovascular, sort of prioritizing, right? You want your cardiovascular risk to come down. That's the main priority. So, even if there's this potential risk of type 2 diabetes or this increase in blood sugar, if you have very high LDL and a lot of risk factors, then you've got to kind of triage your priorities. In lower risk, you want to, be informed and understand and ideally not operate from a place of fear, but just an informed place. It's also really important to take coenzyme Q10 if you decide to take a statin, because it depletes this antioxidant that is helpful for heart health. So you want to take ubiquinol or CoQ10 alongside a statin, and that may mitigate some of the more common side effects that we see. So when would you consider a statin? Maybe because you have known cardiovascular disease, you have diabetes with additional risk factors, you have very high LDL, especially familial hypercholesterolemia, you have high ApoB or high calculated risk, and you're making a shared decision with your healthcare providers who are considering your age, your family history, your inflammation levels, your metabolic health. And you're talking to your doctor about benefits, risks, and you're hoping that they take into account your patient values. This is, again, why it's so important to do longer sessions. Your body is not a machine that you just are tweaking levels of. You're a whole person with memory and ideas and values, and there's meaning behind taking a pill every day, and meaning behind supplements, meaning behind making a lifestyle change. You're the one taking action. There, deciding when to retest. You're this active participant in your health, right? Your doctor can recommend any medication they want, but if you're not taking it, if you're not, it's kind of your job to take that in. It's your job to go and get the blood work. And so how wonderful if you're participating in your healthcare by understanding how things are working. You don't have to be a doctor. You don't have to understand it completely, but enough that you can participate or, be engaged in the conversation would be wonderful. And have someone listen to you and take your personality, your experience, your self into consideration. Biopsychosocial, biological, psychological, social, environmental factors that influence our health, right? Not just a number on a blood test, right? So lifestyle. So this is often the first line recommendation in intermediate risk cases, which is wonderful because this is obviously the naturopathic wheelhouse. It's good to give it about 3 to 6 months to see if you're responding. That'll tell you, right? If you test at 3 months and you see a reduction, it gives you an idea of, okay, let's keep going. How's that going? Maybe you want to be a bit, there's different approaches to lifestyle change, right? Sometimes there's the gung-ho, let's go, all or nothing. Sometimes I'm that person. Most people, I would say, are more about let's tweak this thing so that it's sustainable, so that you can live with it, so that you're not white knuckling, so that you can continue this on your best day and your worst day, more or less, right? It's a sustainable long-term plan. And so sometimes we want to measure to see how effective those changes are, and if we need to stack more changes on top. Or like, again, it's all up to your values. You might decide, okay, like that's good. I'm going to go with a low dose statin and continue my daily exercise, But again, like part of what we're doing is assessing trends, right? We're seeing like, okay, you changed this and we saw this number go down. And then this year there was a lot of stress in your life and it came up. So we're like looking and understanding your body and how your experience can influence your numbers and how you feel. We want to definitely focus on insulin sensitivity. So we want to know what your fasting insulin is in the context of cardiometabolic health. And that may involve reducing refined carbohydrates and sugar, increasing protein, focusing on whole foods, adding in movement, daily walking, strength training are two big ones. Sort of think of a healthy diet involving whole foods, fruits and vegetables, proteins, healthy fats with like, it's kind of like the food pyramid. You have an exercise pyramid of like daily movement with walking, strength training, soluble fiber, lots of evidence for that, modestly reducing LDL by improving its clearance. So the soluble fibers found in oats, flax, chia, psyllium, and legumes. So sometimes like a more systematic protocol where you're taking a couple tablespoons a day of psyllium fiber, and that can also help with digestion. There's lots of benefit to soluble fibers outside of lowering cholesterol. Healthy fats, there's evidence that sort of a Mediterranean diet style of fat intake, so more olive oil, nuts, seeds, avocado, fatty fish, can raise HDL and lower LDL. And like I said, sometimes saturated fats like coconut oil, butter, it's like these like natural saturated fats can raise HDL and lower LDL in certain people, but can also raise LDL in other people. So, if you're on a ketogenic diet and you're feeling great, you might see an elevated LDL, and then you may want to do some investigation around that and understand that a bit more. And you want to also focus on reducing inflammation. So this involves managing sleep, ensuring that you're getting better quality sleep, more efficient sleep, an appropriate duration of sleep, stress management, quitting smoking, moderating alcohol, like all of these lifestyle things. And these are really kind of basic things that we always list. Eat well, whole foods, exercise, lower your stress. But the art is like in sitting down with you and thinking through how your day goes typically, or your week or your year, and like looking at how we might help with changes. And change is not easy, right? Change involves internal and external motivation. It involves making decisions throughout the day. It involves planning, and it involves trying things and maybe those things not working, maybe other things working, reflection. It involves a lot of different things, and it's, can be very helpful to do it, work all of it out with somebody, right? Right. I could just tell you like quit smoking. It's very different than us like actually having counseling around smoking cessation or harm reduction or talking about it, or the idea of like the stages of change and motivational interviewing, and which involves resolving ambivalence around change, right? We often are like, oh, I've always wanted to quit smoking, but and so we're trying to tip you to the side of, okay, maybe I'm going to do this now. The confidence, the self-efficacy to do those changes. In a big thing here too, that I often don't talk about in these types of lectures, but self-compassion, right? Because there's often, when we talk about lifestyle and diet and exercise, there's often so much shame wrapped around in it. Often my first introduction to lifestyle changes was when I was a teenager, and it was like Weight Watchers and cardio, and it was like a punishment. So there's a lot of framing that we have that maybe we haven't really unpacked or examined in a while. Maybe we hold a lot of shame. Maybe we've tried things, we've been successful or haven't been successful. Maybe we've fallen off the wagon. Maybe we're in a season of life where we don't feel that great or confident in our bodies. So there's a lot to unpack. It's not as simple as just like eat whole foods. Yes, great. We definitely want to eat more whole foods. I don't think there's a lot of people contesting that, but we want to look at like, okay, why, like, how do you do that in your life? Does that make sense? And retesting. So after lifestyle changes, you want to look at 3 to 6 months. So you want to give it some time, and, tracking can help us with tweaking things and with motivation. After medication changes, you want to check in 6 to 12 weeks. And then once stable, you check once a year, typically. So we talked a lot throughout this lecture about how a naturopath will organize a case like this. Right? Like I'm just thinking about patients that will be like, I have high cholesterol. And it's like, all right, I have high cholesterol. Or at a dinner party or something, someone's like, I have high cholesterol. What should you do for high cholesterol? And sometimes I'll just be like, psyllium fiber. So a naturopath, obviously I can't answer that question, right? Because as you're understanding, it involves a full intake. So it's more like, let's sit down and talk about like, what are you eating every day? No judgment. Let's just run through like a breakfast, lunch, dinner. How do you make food decisions? What types of foods do you eat? Any foods you restrict? Any like preferences, cravings, all of that. Stress, sleep. What time do you go to bed? What time do you wake up? Are you staying asleep? How long does it take you to fall asleep? Do you wake up rested in the morning? Movement, how often? What types? Are you feeling restored from exercise? Are you feeling an improvement in your body from exercise? Hormones, where are you? What season of life are you in? What are your periods like? How heavy are they? Let's get your hormones tested possibly. Gut health, any bloating, any fatigue after eating, how are bowel movements, any heartburn, any gut pain, any gallbladder disease, and so on. And then we work on a personalized plan, right? Nutrition strategy, targeted supplements, lifestyle shifts, and we monitor and adjust. So we might repeat labs, track your symptoms, refine the plan. And the key message is it's not just about lowering a number. It's about improving the entire terrain of your body, right? Biopsychosocial, right? Versus a reductionistic model, which has, since the 70s, we've talked about moving away from a reductionistic model, but it's very tempting when you have scarce resources to lean on reductionism, because you're just about like, oh, this number's high, let's lower it, here's the medication. Obviously it's much more complex than that, and you deserve complexity when it comes to your health in your life. You deserve the option for complexity if you want it. And so in summary, cholesterol is a tool of understanding our cardiovascular disease risk. It's not a diagnosis, but it also helps us understand our metabolic risk. It helps us understand our capacity for hormone building, our mental health, and context matters more than any number. And you deserve clear explanations, personalized care, shared decision-making, someone that's going to evaluate more angles. And you also deserve to understand this. So I encourage you to grab your cholesterol panel, watch this again, save this for later for when you want to understand your cholesterol. Go back over some more confusing aspects of it, like the ApoB. Use this lecture and this knowledge to advocate for yourself. So my name is Dr. Talia Marcheggiani. I'm a naturopathic doctor. You can follow my podcast. I'm going to put some more of these out more frequently, maybe less structured with PowerPoints, but I like doing this. And if you liked this lecture, I encourage you to check out my course, a new course that I created at the end of last year called Rhythm and Flow, an integrative hormone course, Science and Self-Care for the Circadian Woman. So I have been focusing on hormones throughout my naturopathic practice over 10 years and the intersection with mental health. And I wanted to create a document, a living resource for patients and the public to understand their hormones. Because our hormones are, first of all, what is a hormone? How do hormones interact in our body? What do they do? Common hormonal symptoms or hormonal health conditions like PMS and PMDD or heavy bleeding, fibroids. How are these influenced by hormones? What are common hormonal interactions or quote imbalances across the body? How might a naturopathic doctor from a more holistic perspective understand hormones and what can you do about it? So this is a resource where the intention was to kind of compile things that I've learned and organize the information across the more than a decade of naturopathic clinical practice and articles I've written and courses I've taken and books I've read about hormones, to synthesize it, to rely on resources that have really helped me, and to put that information in a place that you can understand it, you can peruse it, and you can, so that you can have that knowledge too, and that you can use it with your healthcare team or your own lifestyle changes. Because so often I find myself wanting to educate and wanting to teach my patients. Docere is the root of the word doctor, and it means to teach. So doctor is a teacher, and you deserve to understand how your body works. That was my passion. That's the reason that I became a naturopathic doctor. It's the reason I studied life sciences in undergrad, is I wanted to understand how the body works. And that's been my mission. And so I wanted to put that information in a package that could be accessible. It's kind of a choose your own adventure where you can go through the lectures, you can read, or you can listen on your phone like a podcast, or you can watch lectures just like these. So it's in the similar format with PowerPoints, filmed on Keynote. So check that out. I'll put a link in the comment section where you can check out the course. And until the summer, I'm going to make the course alive. So you can send me, while you're going through the material, you can send me questions, and I'll make videos that address those questions so that we can like fill in any gaps that you have. I want you to take the information, and I want you to experience it, and so it can be a co-creation between all of us. And there's no timeline. You don't have to finish it all in a certain amount of time, right? I know a lot of people say that they buy courses and then they don't look at them. This is a document you can always return. You can watch one lecture, sit on it, come back. You can have it forever. Even if I move my course content to another platform, I always let people who have purchased it access it at the new platform. So you always have that content with you. So thank you for listening. We'll talk soon. I'm Dr. Talia Marcheggiani, and have a great day. Don't forget to get outside.